the whole world smile. By your kindness and talent, hence sharing your commitment to help the whole world smile. By your passion and intention, sharing your experience and make the whole world smile. By your kindness and talent, hence sharing your commitment to help the whole world smile. By your passion and intention, sharing your experience and make the whole world smile. By your kindness and talent, hence sharing your commitment to help the whole world smile. By your passion and intention, lend us a hand. By your passion and intention, lend us a hand. Come to join with us, ICD, give us your hands.
Good evening, everybody. Welcome to our ICD webinar. This is the second webinar for the month of March. We will start shortly in about 3 minutes time. Our speaker has also joined, and tonight also we are joined with our president, Dr. Hao Kim Chuan, is also joining us. So we just about 1 or 2 minutes more before we'll begin this tonight's sessions. Please be patient. Good evening, Dr. Hashim. Can you hear us?
Yes, Prof. I can hear you very clearly.
Dato, you want to on your video?
Yes, I will.
Okay, thank you. All right.
Thank you.
All right. So, ladies and gentlemen, we'll begin our tonight webinar sessions. And tonight we have a very interesting topic, and of course, we presented by a very renowned person in professional dentistry, not just in Malaysia, also in the region and also some parts of the world. So tonight, our speaker is Emeritus Professor Dato' Captain Hashim bin Yaakob. let me to give a short some biography of Dato' Hashim. Of course, if I want to read a full CV, it would take quite some time. Okay, right. So currently, Professor Emeritus Dato' Hashim is the Professor Emeritus at University Malaya, and he is also the consultant dental surgeon at University Malaya Specialist Center, and also at the KL and Avicenna Hospital in Shah Alam. Dato' Hashim is the former Vice Chancellor of 5 universities, mainly University of Malaya, International College of Nursing, Kuala Lumpur, Kuala Lumpur Metropolitan University, Quest International University, Perak, and Emeritus University, Kuala Lumpur. In terms of awards, Dato' Hashim has outstandingly contributed to education, World Chancellors and Vice Chancellors Congress, and winner of 21 medals for scientific inventions at the international and national levels. He also won the Excellent Scientist Award by the Ministry of Higher Education in 2004 and 2005. Dato' Hashim is the Malaysian, also won the Malaysian Literary Award, Hadiah Sastra Negara, in 2001. He was also awarded the Excellent Service Certificate from University of Malaya in 1998, 1999, 2000, and 2001, 4 years in a row. He was awarded by the State of Kelantan Sultan, Sri Paduka Setia Mahkota Kelantan, SPSK, yang amat terbilang, and also that in 2004. And earlier, he was awarded Datuk Paduka Setia Mahkota Kelantan yang amat terbilang, DPSK, in 1997. He was also awarded the Panglima Angkatan Tentera, the Military Honor, PAT, conferred by the King of Malaysia in 2005. Dato' Hashim, that was his award. In the one contribution, he is the Honorary General Secretary of World Youth Foundation from 2021. He also engineered the recognition by the General Dental Council of United Kingdom, the Bachelor of Dental Surgery for University of Malaya in 1997. He also set up the FDS RCS examination and clinical attachment of the Royal College of Surgeons of England in Kuala Lumpur in 1997. He also introduced the postgraduate degree in dentistry, the first in Malaysia at University of Malaya, mainly the PhD, MClinDen, MComDen, is Community Dentistry, MOF, MDS, and MDSC, and placing among the top 200 US world best university in 2004-2006. Professor Emeritus Dr. Hashim Yaakob also has signed an MOU for University of Malaya for 52 other universities, including Cambridge, Peking, Carnegie Mellon, California, London, and he's the chairman for establishment in the Department of Malaysian Studies at the Cairo University in 2005. He is also the chairman of the Council for Education in the Advancement of Kelantan in 2005, a consultant to the formation of the International College of Nursing in 2008, and the chairman of the formation of Emeritus University 2015, and chairman of Innovative of International College Petaling Jaya, and the Chains International Shah Alam. So that is part of Dr. Hashim contribution to the education, and also not just education and other. He also involved in the Youth Foundation, World Youth Foundation. Now, so tonight, Dr. Hashim, Captain Dato' Emeritus Dr. Hashim Yaakob, got his DDSC honors from the DDSC honors, and also Fellow of Royal College of Pathology from the University, FRC Pass from the UK, FFOP from Australia, and FDS RCS Addendum from England, FDS RCPS from Glasgow, and he's also the Fellow of Academy Science Malaysia. Of course, he's got an MSc London, and of course, he has additional degree. I mean, he was graduated from Otago, BDS from Otago, and on top of that, Dr. Hashim also have a certificate of biology from the United Kingdom and also diploma in Islamic Studies from University Islam Antara Bangsa Malaysia, UIAM. So tonight, Dr. Hashim has an interesting topic to share with us. His topic tonight, we've come. Actually, Dr. Hashim is his expertise is actually in oral medicine and oral pathology. So he has coined up a title of lecture tonight to see the title, very catchy title, "Come Sit in My Brain and Feel the Beat." Dr. Hashim, the stage is yours to share about it. Thank you.
Thank you very much, Dr. Professor Muhammad Ibrahim. That was a full lecture by itself. It was very mouthful. Thank you very much. I am Hashim Yaakob, and I'm very glad and happy to be with you tonight. And I hope whatever I have to share with you could be of some benefit to you. Right now, do I put the slide or do you put the slide? Do I press somewhere? Can I put up a slide?
Dr. Hashim, I can control for you, but it's better that you control yourself. If you open your slide and you share the screen, and you can control it on your own.
You know what to do. Well, before
Are you okay? Otherwise, I can.
Yes, can you please do it? Simply because I'm not able to use my fingers because I just lost my fingers.
Okay.
All right, first slide, please.
Yeah.
Right. Now, today I would like to talk about facial psychogenic pain. And for those of you who could read Mandarin, please read it for me. Because I was told that this will go far and wide. No, before, next. Don't go yet. I think we are going so fast. Can you please go back to the first slide?
Wait.
First slide, please.
Wait, I just...
All right, that is the first slide. Thank you very much. Is that all right, Prof. Mat?
Yeah, go ahead. Go ahead.
Yeah, right. Thank you very much. Now, psychogenic pain. The title is, have you ever seen the red rain? Come and sit in my brain and feel the pain. Only last week, I saw a patient who was suffering from extreme depression. And she came to me. She was quite a brilliant and clever person and said this, gave me this title. Have you ever seen the red rain? Come and sit in my brain and feel my pain. I said to her, I shall reply a poem later on after I have examined you. And she was quite happy to hear that. So off we went, examined her, and I'll tell you later on about what happened. Now, as we know, all dentists know about this, that facial pain can be divided into very, very many categories, which we all know. Pain that comes from the teeth itself, from the periodontium, from deep occlusal disharmonies, from the masticatory muscles, from lesions of the oral mucosa inside the mouth, from nerves, from blood vessels, Rayford pain, and finally, the least understood lesion is the pain of psychological origin. Now, can we go back? We go back to one slide, please. Go back to one slide. Go back to the previous slide.
Yeah, I'm going back. It takes some time, actually.
Never mind. If you cannot, never mind. Stay there. Now, if we were dealing with any pain which is very undiagnosed. We do not know what it is. It is neither of those things which I have just mentioned just now. And if we were to see also that there is the presence of psychosis, the presence of hysteria, hypochondria, psychological, then we could start thinking about the pain as being psychologically oriented. Yeah. In other words, it is a diagnosis by exclusion. If you don't see any, if you cannot diagnose any of the things which you have, which you are familiar with, which we said just now, then the last thing is to determine whether is this psychologically oriented pain. But psychogenic pain is real. It is real. It originates in the mind. Really, frankly, it originates in the mind. And the patient experiences real pain. And now we are going faster. And they really experience the pain. But there is total absence of physiological cause. You look for it, you don't find it. It becomes very difficult to accept it because it lacks clear definition. And diagnosis is, of course, by exclusion of others' pain. Thank you. Next. All right. Now, there are 4 main groups of patients. 4 main. There are a little bit more, but then we need to know only about 4 main groups of patients who appear to suffer from psychogenic pain. Who are they? Normal individuals. They are very normal individuals, but they are under extreme stress. Those with personality traits such as hypochondriences, who worries about health unnecessarily, and the neurotic patients, often very depressed people, and rarely the psychotic patients. Psychotic patients don't normally express pain, but the neurotic ones, they do. Next, please. Now, the symptoms of depression. What I saw today, last week, in the patient was really a combination of a few of these things, which I am going to say now. These people who suffer from depression really have negative mood states and hedonia. And hedonia is just simply things which describe loss of interest in things which the patient used to love doing before. If he likes to go and see movies before, but when you are under depression, then you have lost the interest to go to see and do what you like doing best in under normal circumstances, right? And hedonia, that is, right? No longer is this patient enjoying the pleasures that she has once enjoyed. Finish, close. Resignations, doesn't want to do anything. She resigned to a quiet life, you know, not interested even to listen to this lecture today about the pain in the head, and loss of appetite. Some people become thin because they lose appetite, but some people suffer from hypophagia. Hypophagia is simply great desire of food, non-stop eating, and excessive eating. So either they became thin or they became fat, right? When they are under depression, loss of appetite or hypophagia. Early morning, you will be waking up already, not to do the exercises, but they cannot just sleep. Hypersomnia, heightened irritability. This type of people are normally quiet, irritable. Little things will make them irritated, and attention is very much decreased. They have lost their focus most of the time. These are the symptoms of depression. If you come across people like this, then having pain in the face, then you could probably start thinking about, is she under depression? Because when you see a patient, they will complain about facial pain. Pain in the face, but they do not actually really know and exactly where it is, except, oh, it is all around here, it is all around the face, and so on and so forth, but no real pinpoint positions that they can tell you. Now, symptoms of stress, let's go to the lesser one, which is stress. Now it is depression. But before that, a person may be stressed. Next slide, bro. Right, symptom of stress. Now, this is all due to heightened autonomic arousal. Now, the blood pressure is raised. The person breathes very quickly, shallow breathing, increased heart rate, generally increasing muscle tension, causing the pain in the face, right? And sense of being overwhelmed, the sense of being defeated, lost to all sorts of challenges, defeated. Now, this type of person will be agitated, will be frenetic, behavior-wise. Next, please. Now, system of stress, that is what we have just said just now. The next slide. Before you have stress, you may have anxiousness or anxiety. What are the symptoms of anxiety? Well, as above, right? And he will report the characteristic noxious subjective symptoms of anxiety. Now, patients who are anxious would really be worrying about things, worry, apprehension, anticipation of threat. So he's always anticipating threat, danger, or harm. And he is very nervous about it. A good example is an anxious person suffering from anxiety would be anticipating pain from a simple local injection before dental treatment. That is a simple example. Next page. Now then, psychogenic pain. A person who has got psychogenic pain, especially at the extreme highest level, which is depression, may have a combination of these signs and symptoms. He may not present all, but he normally or she normally will tell you that she has tight muscles along the forehead. The muscles around the forehead seems to be very tight, as though there is a band around it, feeling like a band around the head, especially around the muscles of the forehead. And then whether he has an eye bag or he hasn't got an eye bag, he will have twitching sensation just beneath the lower eyelid, twitching, and twitching. Jaw ache is quite common. And the muscles around the cheek will pulsate sometimes, pulsating muscles around the cheek. Now, this is really extreme stress and extreme stress going down to depression. The saliva will be increased. And of course, the dirty tongue is not a usual one because it all depends on whether the person keeps oral hygiene or not. The one I saw last week had a very clean mouth, even though the saliva was quite copious. Next, please. Now, a person who has got psychogenic pain, especially the one which shows depression, will usually have description of bizarre pain, very dramatic, you know, things like buzzing pain, ring, band around the head. Sometimes people will say, I feel like having a crown around my head too, a crown of thorns, not a crown of gold, but a crown of thorns around the head, because he is very, very delusional. Worms, electrical wires inside the bones keep creeping them. Some of them, they will describe that to you. And the pain is diffuse and it is vague. And he cannot localize exactly by pinpointing at the area, but he can tell you where the area is. where he's having it. Not in children, because children don't worry anything about anything, almost. We find it in late adolescence and in adults and people of higher age than that. So these are the signs of people who are really depressed, agitation, getting angry very quickly over little things, sleeplessness, sleep, psychomotor retardation, Everything is slow about this guy. Harried speech, he cannot pronounce things properly. For example, would you like to have a cup of tea? He probably will say, would you like to have a cup of tea? Right? And others of psychotic reactions. Let us go to the next slide. Now, talking about this will be quite meaningless until and unless we understand a little bit about some abnormal mental states. Let us go through it quite briefly. Now, there are two types actually, the neurosis and the psychosis. People say he is neurotic, but do we really know what we mean by a neurotic person is? And psychotic, he is psychotic, he is neurotic. Now, neurosis, though abnormal, though he has pain, though he behaves abnormally, but he remains in touch with reality. He is in this world and he is aware of his sickness and he wants to overcome it. And that is neurosis. But psychosis is divorced from reality. He is divorced from reality and he is most of the time not in this world, inverted commas, and description of symptoms of his pain is bizarre, just like what I have just mentioned to you. But not only pain he'll be complaining to you, he will be doing some other things too. Like for example, many years ago, I had a patient coming to my clinic with carrots in the ears, 2 carrots in the left and right ears. And he came to the door of the clinic and asked the nurse and us and me and said, "Doctor, can you please tell me what's wrong with me?" What do we do? All we ever need to do and say is that try the mouth. But he was not doing it properly. So try the mouth. Perhaps he will be able to eat this carrot. Next. Now, neurosis. Let us talk about neurosis. There are a few things about neurosis. One is depression, the reactive depression. Reactive depression simply means bereavement. Somebody died yesterday because of COVID, for example. It may not be because of COVID. Then, of course, we become depressed, but this is a reactive depression. We reacted to the happenings. We reacted in bereavement. We were sad. But this goes away. So that is fine. That is all right, because as soon as the fellow dies off and put him in the grave, probably 1 week later, you forgot about it already. The endogenous is different. The endogenous is quite different. It is not reactive. It is there. It is there all the time. It comes out of inferiority complex, which become worse and worse, worse and worse, especially when he fails to arrive at what he wants to do. Now, hysteria, conversion state. What is hysteria? Yeah? We sometimes think that hysteria is when a group of girls or boys, normally girls in the hostel, become hysterical, shouting, crying, and so on and so forth. But actually, medically, that is not hysteria. Now, a hysteric suffers from functional abnormality, meaning, I'll tell you afterward, functional abnormalities of apparently neurological origin, do no neurological abnormality can be found. Example, hysterical paralysis. You may be paralyzed, but when the doctors examine your nerves, there's nothing wrong with it. So this is hysteria. Means functional loss, but without neurological abnormality. Blindness, for example, hysterical blindness, deafness. People go blind sometimes, and they finally can look again, can see again. Pain is the one which we are interested in. Pain, but actually there is no real cause to it. Not only neurological causes, but other causes. Right, so hysteria. Next, please. Number 3, obsessive compulsive state. Oh, he is compulsive. He is obsessive compulsive. Now, uncontrollable behavior. Cannot control his behavior. And he is over-conscious about certain things. Right? If you are associated with the obsessive compulsive state of persons and friends, you will come to know very soon that these are people who are very, very over-conscious about many things, about health, about cleanliness, about many, many things, about how the chairs are arranged and so on and so forth. Anxiety state is the other one, may express as a phobia. You are anxious, so you have anxiety. So it may be expressed as a form of phobia. Hypocondriences, most people know what this is because it is no confusion. This is worries about health. Little sounds from the tummy, little ringing from the ears, this will make the hypochondriac go wild and mad about it. Next, hypochondriac. Next one. All right, the psychosis. The psychotic fellow is quite different from the neurotic fellow. Psychosis. Now, there are a few types which is divided in this category. One is the so-called schizophrenia, which a lot of people knew about it. Yeah, schizophrenia. Now there are 2 types of schizophrenia basically. And that type called catatonic form, this patient sits quietly and motionlessly and does not do very much. He just keep there wondering why he is there, why he is in the world, worrying about things. He's just out of focus, sitting down there, just quietly. And then the paranoid one. Of course, the paranoid one is totally different from this guy. The patient suffers delusions. He has a lot of delusions. I suppose his delusions are mostly unachievable. Yeah, he has delusions of being persecuted. Delusions of being persecuted. Now, so these are the paranoid form of schizophrenia. But there are people, of course, do not fear or do not have delusions of being persecuted, even though they have been persecuted. Next one, please. Now, psychosis, yeah. Disorganization of personality, his ideas are very incongruent, congruent. There is no sense to make out of it. Loss of contact with the reality. Totally lost with the reality. And strange enough, these schizophrenics, they are very tolerant of pain, very tolerant of pain. They don't suffer pain most of the time, but their behavior is different. They're out of the world. Next. The psychosis. There are the manic and there's the depression. The manic type is always carefree, happy, elated, optimistic about things that they want to do and of the success, energetic, friendly, very energetic and friendly. I suppose if you want to get things done, you will have to have some manic characteristic in you, whereby you will be energetic and friendly and optimistic about the outcome. So when we started our effort to have our Bachelor of Dental degree recognized by the General Dental Council many years ago, I think some of us were a little bit manic. But of course, we did not suffer from psychosis, but we were a little bit manic. We were elated, we were optimistic and energetic to get those things. Now, this is in contrast to that, fellows who are depressed. The depressed one is always getting annoyed, irritated, and can be quite violent sometimes. So when you deal with patients who are psychologically disoriented, suffering from depression, be careful of the depressed one, because they can be a little bit rough. Next, please. Now, the other one is endogenous. This is the one which is very difficult to sort out. The one which has got, the one who has got endogenous depression. You do not know what is the cause. Don't really know. But such a person will feel very sad, feel very helpless, loses self-esteem, feels guilty about all sorts of things, think about what the world thinks of them, and apathetic about food and sex. Apathetic means no interest about food, no interest about sex, no interest about almost anything. Now, of course, it overlaps with reactive depression. It can overlap with depression, which is of the type reactive. Thank you. Next slide, please. Well, that was my painting, because at one stage of my life, I thought we have got so many clever people in this country, so many graduates in this country. And I remembered the saying by Edmund Burke. It says, when good men do nothing, evil will triumph. Good men and women must not do nothing. Otherwise, evil will triumph. Next, please. Now, the most common types of orofacial pain with a strong psychogenic components are, these are the few. I see there are a few more, but I think they are not strong enough to be considered as psychogenic facial pain. But these four, you may believe that there is some component of psychology that they bring in. Atypical facial pain. You have a facial pain which you can really diagnose. But in this case, you just cannot name it. So therefore, we call it atypical facial pain. Facial pain which is not typical. Facial pain which I do not know what diagnosis I would want to give. So therefore, you call it atypical facial pain. We'll see about it. Oral dysesthesia. Oral dysesthesia, burning mouth syndrome. This is quite common. The burning mouth syndrome is quite common, especially when you've gone past 50 years of age. And especially they are in commonly in the female patients. Temporomandibular pain dysfunction. Well, you can believe that this has got a psychological component, but you can also believe that it is not always true. It can be other reasons for causing this as well. Atypical odontalgia. I come across this atypical odontalgia, and it is very, very frustrating in treatment of these things. Now let us see what it is. 1, 2, 3, 4. Next, please. Atypical facial pain. You see, the patient will say, I have dull throat in here. Non-muscular. It's not in the muscles. Non-muscular. And when you look into the mouth, you can see inflamed tongue. The tongue appears redder than before. And then it can appear in any side, floor of the mouth, the cheek, and so on and so forth. And the pain is really by eating. Most people like keep eating, then eat, and then they say, if I eat or if I drink, then the pain get relieved. Although the mucosa is hyperemic because there is some inflammation going on. Why is the inflamed mucosa? Because the patient must have been chewing on the structures without hurting them at this moment, but it is being pressed, right? So it being irritated, so it goes red, right? Inflamed. History of multiple extraction is sometimes being given to you, but not all the time. Teeth may be tender. And when you examine the teeth which is tender, it is normal. You find that it is normal. There's nothing wrong with it. But yet it is tender, right? Emotional disturbances. That this type of person, if you examine carefully enough, not on the first round, not on the second round, sometimes not the third round, the fourth round, this patient will surrender to you and will tell, actually, doctor, I have this problem. Actually, doctor, I would like to listen. And you must listen. Now, pain absent or waking. You see, when you wake up, the pain is not there. Unless he is a bruxist. If he is a bruxist, you will feel that the muscle of mastication is taut, is taut, but it goes better as the day ends, as far as the taut and contraction of muscle. But the pain builds up later. It is worse in the evening. No pain in the morning, especially, but it builds up later. By 5 o'clock, the pain is worse. Simple. The reason is very simple, because he is mentally disturbed. He keeps thinking about his problem, how to solve it. He can't solve it. So he gets worried and you get worried and so on and so forth. All right. So these are some of the tricks this patient has. Next, please. Now, what do you do here for atypical facial pain? Here is a good table. Now, if you see an atypical facial pain, which you do not know what the diagnosis is, then you will ask yourself, is there any organic lesion? Have you excluded any organic lesion? If the answer is no, if you say, no, I have not excluded any known organic lesion, then consider organic lesion. You must consider organic lesion because you have not eliminated it. Now, if the answer is yes, I have already excluded organic lesion, I do not know what it is, then you can go straight away almost to regard this as a psychologically oriented pain of the face. And I like this amitriptyline 50 milligram nocte. Give this one. And the pain control after 1 month, you give him 50 milligram every day at night. Let him go off for 1 month with his medicine. Make sure he takes it. And is there any improvement after 1 month of it? If the answer is yes, then you consider the dose. Meaning you have been giving 50 milligram for 1 month. If it gets better, yes, then you halve it or reduce it until it becomes to the most minimum. But if the pain is not controlled after 1 month, the pain is still there, then you increase the dose or trial doxepin 25 milligram nocte. These are two different medicine. Yeah. So increase the dose. Either you increase the dose of amitriptyline or you give a new medicine, doxepin, which is quite good, recognized and approved by the Kementerian Kesihatan Malaysia. Now, if the pain is controlled after 1 month with an increased dose and with a new doxepin drug, then if it is yes, you consider dosing to reduce it. But if it is no, increase dose or try this fluoxetine 20 milligrams. You try this, right? And if at the end of the day, with all this, you still cannot do it, I think it is time the psychiatrist must come in. Yeah, as an ordinary dentist, you would refer to the specialist first, and then if the specialist are out of his wits to treat this, then of course he must work with the psychological, medical people, psychiatrists. Next, please. Now, atypical odontalgia. Odontalgia means pain in the teeth, that's all. But normal odontalgia is because of something is wrong with the pulp. Something is wrong with the dentine. But this is not typical. When you examine the tooth, it is completely normal, completely sound. And yet the patient keep telling you, pain here, doctor, I pain here, here. And he can point it out to you. Normally it is localized to one tooth. I keep pointing to that tooth. I have pain here. Most of the time it is in the premolar. But there are times when it is in the incisor region as well. So this mimics dental or periapical pain or perio infection. But when you look at it, this person normally have got very clean mouth. So there's no such thing as infection or dead tooth or whatever it is. Okay, one tooth, normally one tooth, confined to one tooth, normally, with one tooth. And then it may cross the midline, blatantly, it may cross the midline. Normally, any organic pain because of blood vessels abnormality or nervous neural abnormality don't normally cross the midline, right? But this one just cross. Anytime you like, it just cross, right? Sharp, stabbing, intense, exacerbated, repeated by touch and temperature. You touch it. Am I touching? Yeah, you touch it. I touched this a few months ago on a patient who keep telling me there is pain here. And yet on examination clinically, radiographically, EPT and so on and so forth, whatever, cracked tooth syndrome examination, none of it. And yet you touch here, oh, sakit. Sakit means pain. So this is atypical odontalgia. I don't know what it is called in Mandarin, but I've written it. I hope it is right. Next. Now, atypical odontalgia. It is more or less, some people call it vascular toothache. It is a toothache resulting from the vascular problems. Now, some people called it many years ago facial migraine. Migraine normally is not in the teeth, but this is facial migraine. I think you just forget about all this terminology. Just stick to atypical odontalgia. Now, of course, people like this are usually found with some problem of the emotion. Absent adequate dental costs. You look and look, you don't find. Periodic and recurrent pain. There are times when it stops. There are times when it comes in, just like migraine. Patient able to locate precisely. The good thing about this is that he tells you which tooth it is. Now, no response to usual dental treatment. You don't do anything to this thing unless it is dirty, that you have got to clean up the whole place. But if it's clean, what do? There are a lot of dentists who would do RCT because they think it is due to the dead pulp or whatever it is, they do RCT. But when the doctor does an RCT on that one tooth, it migrates to the next tooth. He does another RCT, it migrates to the other tooth. And finally, the patient will have teeth full of RCTs in that quadrant. Next. Now, how do you confirm this? Crudely, you know what you do, what I normally do, I don't come across this type of pain very, very often, but from time to time. And I learned from long time ago, you try and catch his carotid pressure. So where you squeeze the neck at the carotid area, very little blood flows to the teeth upward, and the patient feels a little better, doesn't have the pain. You try and do that. That is only a test to see the truthfulness of atypical odontalgia. Now, glutamin tartrate is the medicine or the drug that you use to treat migraine. You do this fellow will get relief also. Analgesic block, if you block the thing with your analgesia, either you will have a decrease in pain or increase in pain or nothing happens. It's ridiculous. This one doesn't mean anything. So treatment, what do? You must resist extraction. Otherwise, the patient will remain toothless. Resist extraction, psychotherapy. So the dentist should learn a little bit of psychoanalysis, psychotherapy, and psychoanalysis so that you could manage patients like this at your level. And once you throw the card, throw the tower in, refer it to somebody else. but at least you know that you have come across things like that which you can manage. Sometimes you can manage it yourself. Next, please. Now, burning mouth syndrome, this is very common. You know, in the clinic at the University Medical Specialist Center, University of Malaya, I see elderly people with burning tongue quite often. Burning tongue. The tongue just burn like it is on fire. What do we do? Now, burning tongue normally is burning itself only at the anterior part. It doesn't burn towards the posterior, right? The mouth mucosa, the lip, the anterior hard palate, alveolar ridge are affected only on the anterior parts of it. Dysesthesia sometimes, you feel dysesthesia sometimes, but this is not all the time which you will see dysesthesia. Now, this aesthesia, the patient may tell you, sometimes I feel like an electric shock coming through the tongue or the place where it is burning. Tightening of the tongue, tightening of the mucosa, tightening of the lip, tightening of the cheek. Aching, of course, pain, because it is burning. There are times when it is pins and needles. I have pins and needles on my tongue, doctor. Prickling, tingling, those are all words which the patient will use. Yeah, this aesthesia. Dry mouth, the mouth normally is dry. But it may not. It all depends on the causes of the burning tongue. Symptoms increase towards evening. Same, because sleeping time, they sleep. They don't worry about anything. But as they woke up, the problem keeps coming into their head and they are thinking how to cope up the day, how to spend the day. So it becomes worse and worse and worse and worse towards the evening. Patient often associated onset several weeks after dental treatment. Yeah, that one is just coincidence, I think, but this is part that you might want to know as well. Next, please. More next, please, than anything else. Next, please.
Sorry, there's a slide not moving.
Yeah, it is not moving. Give it a punch. I think it is suffering from some psychological problem. It's like sometimes they do.
Okay.
There. Burning mouth syndrome. Differential diagnosis. Elderly person comes to you, I have burning, I have heat, I have fire in my tongue. The thing about menopause, the first thing I used to think was that, you menopause yet? Nicely asked that, are you menopause? Are you worried? There was a patient who came to me, accompanied by his medical doctor. He had burning tongue. And he was quite cheerful, the lady. And the doctor was puzzled. Why is the tongue burning? The first question I asked, I said, how old are you, madam? And she told me her age. And I said, have you arrived at menopause yet? Or what? I said, yes, I have just menopause. Does that worry you very much? Yes, I am very worried about this. Did you tell the doctor? I asked him. No, I didn't tell my doctor who accompanies me. So I said, your burning tongue. This is after examination. Yeah. Your burning tongue is due to you. And I'm very worried about it. You know, if I am a man, I will be very worried still if I suffer from womanopause. So the lady was not happy because she was normal. And then when she arrives at menopause, she thinks she is not normal, when it is actually normal for a person to undergo that. But she worries so much and so forth. All I ever did for this person was just to tell her, sit down with her, it is a menopause, madam, that is making your tongue burn. And please come back to me 2 weeks' time. If the burning sensation is still there, only after if you have believed that this is because of menopause. But if you still worry about your menopause, then of course, there is nothing very much I can do except to give you some anti-anxiety, anti-stress medicine, right? So she never came back to me, and I suppose the medical doctor kept assuring her probably that don't you worry. Don't you worry, even my wife had menopause. Don't you worry about it. So she had not turned up in a few months already. So I suppose that is the first thing that we must be asking. Diabetes can also uncontrolled endocrine disturbances of diabetes, xerostomia can really give that. But normally, not normally. Sometimes it is shortage, deficiency of iron, vitamin B12, folic acid that can cause you a sama-sami, which is after ulcers, as well as this burning tongue. Lingual nerve trauma, of course, it is by trauma, through surgery, through accident, and things like that, can cause burning tongue too. Candidiasis can. But this is very easy to do. If it is candidiasis, give an antifungal, anti-candidal thing, and it goes, and then the burning sensation will go. Now, if she is depressed, she has got psychological problem with it, and as like in menopause, which is not very difficult to treat, all you need to do is talk to her medically, then it will be all right. So this is some of the things which make the tongue to burn. Next. All right, let's see this burning mouth, right? In burning mouth, can you look at your right hand side? This is good table. Take it later on. Now, in the burning mouth syndrome, what you will see is the mucosa red? Is it erythematous? Is it erythematous? If you answer, no, it is not erythematous, right? Then glycosuria or glycemia. If the answer is yes, then it is diabetes. If the answer is no, then you will ask the question, is the thyroid abnormal in one way or another? If the answer is yes, then it is hypothyroidism. This is another one which causes burning mouth. If no, then you will ask, is she taking any drug? This is quite common, taking any drug. You know? Taking any drug? Yes. Then you must consider drug cause. Is it cytotoxic? Is it ACE inhibitors or blah, blah? And then you have to deal with these drugs. If the answer is no, it is not drug, it is not thyroid function, it is not glycosuria, it's not, then abnormal hematological result. Can you see any abnormality in hematology? If the answer is yes, then normally it is because she is deficient in iron, folate, and vitamin B12. Right? If the answer is no abnormal hematological results, right? Then yes is that, no is depression, anxiety, or cancerophobic. Why is that Amelia staring at me right from the beginning? You can see her staring at me. Anyway, look at your left side. Burning mouth. Erythematous mucosa. You always start with that. Tengok whether the epithelium, the mucosa is red or erythema. If the answer is yes, then you ask, is it recent oral irradiation? Has it been through irradiation the patient because of certain lesions? If the answer is yes, then it is mucositis or candidiasis even after radiation. If the answer is no, then you ask again, is it drug? If you say yes, then candidiasis, fluohexidine, you must be taking this. If the answer is no, and you see candidal hyphae present, no, there is no candidal hyphae present. Then consider erythema migrans, which is your geographic tongue. Lichen planus, discoid lupus erythematosus. If the answer is yes, there is candida, then of course you treat that person for candidiasis. So this table is quite nice, produced by Crispy and Scully. I borrowed this for your own purpose. Yeah, it's very nice to remember, easy to remember, good for examination setting. This one. Next. Please, next. Now, the next one is Tmj Dysfunction Syndrome. Some people call it MFD, myofascial pain. Some people call it MPD, myofascial pain dysfunction. Now, all it does is this. There has been a lot of argument between the medical fellows believing in psychological disease and the conservative people believing in occlusion. So finally, they didn't come up with any solution because there is no one single solution. Because TMJ, pain dysfunction syndrome, which we don't use that term any longer, but because it has been used throughout the ages, it becomes acceptable until today. What is the cause? The cause is activity, response, the muscle and joint of the TMJ. And then occlusal contact relation. Now, this is where the occlusalist are good at. And then general condition, your psychic, your social, your medical. If you have got all these three, you will get TMJ PDS. If you have got two, occlusal contact. If you have got one only, occlusal contact relation is out of the way, you will get TMJ pain dysfunction also. If you have got psychological problem, emotional problem, stress, depression alone, you will also get that. But a combination of these three will make it very, very, very real. And the patient will get TMJ pain dysfunction syndrome. And it is a little harder to treat if compared to as though it has got only one etiology. But you can treat this anyway. Come two, come one, come three. You know the reason, so you treat it. Next, please. Now, etiology of stress. Now, how do you explain that this is the reason? The reason is stress. Now, when you have stress, when you are stressed mentally, the internal tension is built up all over the body, including around the face. Now, then it is channeled, if you are talking about the face, to the stomatognatic system, your muscles, your jaw, your joints, whatever there, stomatic system. And then you start clenching at night and you grind your teeth. And during the day, there are people also who will clench their teeth and grind, clench their teeth and grind their teeth. Now, if you do this very often, you will have dysfunction. You are thrown out of function. Your TM joint here is thrown out of function, and then you will have dysfunction. It is no longer working in a proper balance like what you are made to do, but now it has gone out because the muscles contract, muscle spasm. When the muscle spasm, then you have got limitation of mouth opening, you have got deviation of mouth opening, you cannot open your mouth properly, and so on and so forth, and then you have pain. So that is the etiology of stress. Next, let us look at the other one. The evidence will be, if you take a TMJ pain dysfunction syndrome patient, you subject to emotional stress by psychological test by the psychiatrist, you will find that it is high in emotions. But you test this thing, 17-hydroxysteroid, and the catecholamines, it is high. Well, what does it mean? It means that, with the height of this thing going up, increase one of this, there is a lot of belief to believe, a lot of facts to believe that there is a person who is stressful. While, please take it from me, a person may be highly stressed, but he may yet do not have any problem with the TM joint, because human beings are not made to react the same way. I, for example, I have undergone much stress in my life. I never had TMJ pain dysfunction syndrome. I never had facial pain, but I had something else. I know that is what it is. Next, please. Now, is occlusal prematurity the cause or result of neuromuscular joint disorder? You can debate this. For example, a good example. If you start with prematurity of teeth which is premature, But if you were born with that sort of malocclusion, you'll be okay. But it is only the acute malocclusion. Like, for example, you extract a tooth and the one tooth went out of its original position, where you move teeth in orthodontic treatment and a few tooth went out of occlusion. Then you have got a malocclusion like that, and you cause muscle spasm to happen, and you will have Tmj pain dysfunction. So this is the occlusal form of it. But on the other hand, there is this proprioceptive control. Every muscle spindles have this, and it reacts to certain happenings in your body. It will send that signal to the central nervous system, and in that it will send it to the muscle, especially the external pterygoid muscle. And when the external pterygoid muscle reacts, it shortens, it becomes spastic, and it will pull the important structure, which is the disc of the TMJ and the Tmj condyle. So that get into a disunion, and you get a problem with Tmj pain. So Tmj pain, I would normally look at the occlusal one when I see them. And when I see that it is occlusal disharmony caused suddenly, I will send it to the occlusion specialist. But if I don't see those, and then the muscles being affected, especially more than one muscles, then I will attempt to treat so that the muscle come back to its normal length and shape and characteristic, instead of being strained and sprained. Next, please. Now, psychogenic headache. Now, this is just another example. Sometimes people have got psychogenic headache, but you got headache because you are worried about it. And the symptom mimics myofascial pain dysfunction, because sometimes you have pain in your TMJ, it extends down your mandible, is extend back to the back of the ear. It can go to the occiput, it can go to the top of the head. But that is already time when you should be doing it, should be treating the patient with the conditions quite quickly. Otherwise, it can spread to the sternocleidomastoid, it spread to the neck, it will spread to the shoulders, and so on and so forth. Frequently, young women. Luckily, I'm not. Frequently, it affects young women, this thing. Dull, itching, throbbing, sharp sometimes, but normally it is dull, throbbing, represents somatization of anxiety and depression. What does it mean? It represents the pain of the psychogenic headache actually is the somatization, or it is the reactions of the physical body to the mental state, which is anxiety or worse still, depression. Next. We are coming to the end. Now let's see this. I borrowed the slide from Mumford because this is quite classic. Now, this patient is very anxious. Anxiety, suffer from anxiety and neurosis. So anxiety is part of neurosis. Anxious about needles and real, keep reminding the dentist, write letters to the dentist to be very careful, don't inject so deeply, and so on and so forth. So this patient is neurotic. Nobody in the right mind would be writing to the dentist. Some complain of metallic burning sensation when given the injection. Example, women complain of burning pain under the bridge, like this. Give you an example of this woman by Mumford and his gang. He was treating this person. The woman complained of burning pain under her bridge. And the dentist looked at the mucosa, it looks quite normal. And the patient is complaining about certain things which he doesn't like to do. And she was worried about if the bridge is going to be removed because of the pain, because she has spent so much money for the bridge, right? Now, of course, the doctors were puzzled in the beginning. Doctors always have got to be puzzled before they find the real right solution. And when they took a few X-ray, The first one didn't show. They found there is a root remaining in there. So when they remove the root, the pain just disappears. So the anxiety states of the patient was not discovered by the doctors, and then it went on and on until the cause of it. So really, frankly, this is not an emotional problem because of the thing in the brain. It was because there was a cause in it. So that was the cause. In other words, there was an odontogenic cause, and it wasn't psychological. It wasn't diagnosed quickly. That's why it went on like this. Next, please. Now, Mumford is a specialist in this. A student wanted to go for the examination in anatomy and went to the doctor and said, I have pain in my teeth. But the doctors thought that because the students were not preparing enough for the examination and so on and so forth, and decided, and dismiss the thing as having psychological problem, despite of the fact that when they took the X-ray, took radiograph, they saw multiple caries and overhang margins and so on. Those is the one that is causing her the pain, not psychological. So, as dentists, we must not quickly dismiss any case as being psychological oriented. Exhaust the statement, exhaust the examination, find out until you've given up. Maybe you would refer to some of your colleagues and so forth. Only then, if you don't find any organic cause, you contemplate psychological cause. Next, hypocondriences. Now, depression, neurosis. A patient described as having overlay or even psychotic delusion. Now, this patient complained of bilateral toothache, face, headache, bilateral toothache, and face and headache. And tooth roots were removed, which they saw, right? But no relief from the pain. The patient still had that problem. So they didn't know what to do until a few years later, they came back again, the patient to them, and they took a fresh X-ray. And this time they saw there was still another root which was infected, which this did not see in the first round. And when the root was extracted, there was no subsequent pain anymore. Now we have heard about many a times lazy doctors will discard patients and think of it as, this is psychological pain. No, it's psychology, it'll get better. No, must never do that. Next, please. Now, psychological pain is getting higher in number now because of the COVID. Believe me, because of COVID, more people are distressed, more people are depressed, anxious, of course, and depression treatment. The time will heal if it is only depression, if it is not because of getting. But the physician will take charge of it. The dentist will help. Now, but how do you help? Well, you have no money. The housing problem is there. Bad housing problems ongoing. What do? So Professor Harris used to tell me, give him tricyclics to calm them down. Yeah, well, how long can you go with tricyclics? Of course, it helps. And then MAOI is another thing they say. So the clinician has to adjust the attitude according to whether the repeated expression of pain represent something which is masochist, right? Dependent, or is it because of any problem, any other problem? Next, please. Now, hysteria, neurosis. This is quite a classic example of hysteria or neurotic hysteria. A female lower premolar was extracted. The lower premolar of this girl was extracted. And she had numbness of the face. Complete numbness of the face just because you extract. So what was it all about? He didn't know what it was. Then years before this patient had an abortion. Years before the extraction, she had an abortion. And she saw the fetus. So when you want to have your abortion, please don't see your fetus. And she felt guilty for the rest of her life. Next, child was born, and 3 years of age, she died. And she thinks this is God's punishment for her abortion. So she felt bad. She went into depression. And the husband rejected her and called her ugly moron. To make it worse, you ugly moron. Forget about all these things. Now, is this an expression of guilt? Or is it a plea for kindness? Or is it both? So I think this is an expression of guilt and a plea of kindness. If the husband were kind enough and don't call her ugly moron and mistreat her because she is now hysterical about it, then I think it will help. Next, please. Now, obsessive compulsive states. This is another form of neurosis. These people are good personalities, but they are obsessively meticulous about things, as we have said earlier. Over-conscious in approach to life, respond well to treatment. But this type of people respond very well to treatment. Some are able to self-treat ritualistically. Like this, for example, this patient has pain in the buccal mucosa. She tells the doctor, you know what I need to do is I will stroke the buccal sulcus one time, and then 2 strokes will give me considerable relief. But when I stroke it 3 times, the pain completely goes off. Okay. All right, this is strange people, but never mind. Next, please. Schizophrenia, psychosis. Now, people who have schizophrenia or psychosis, will come to you with bizarre description of whatever it is. Sometimes it is pain, sometimes it is just discomfort. Statement like this: I suffered severe pain at 3 p.m. sharp. What notice that? 3 p.m. sharp. And I always say 3 p.m. sharp, then you know this fellow is what sort of person. It's very hot. It goes for only 3 minutes. Who knows whether it's 3 minutes or 2 minutes or 4 minutes? 3 minutes. And probably due to dislocated stapes in my ear. I mean, that is not really stable already. Now, what do you need? Treatment for people like this who are schizophrenia. Sometimes people don't understand this and don't give help, but it is the family, especially, must support. Tranquilizers will help a great deal by these people, not antidepressants, but tranquilizers. He might have painful hallucinations only in minority. Great majority may not have it. Minority have it. But minority out of how many billion of population in the whole world can be a large number. Next, please. Endogenous depression is the one which is not really, which is the one which we don't really want to have. It's very difficult to treat. Now, I give you an example here, again, by Mannhausen, a man who is divorced from his wife. And he goes around bragging, I don't miss my wife. I don't even miss my little daughter. But he drinks 8 pints of beer per night. And then when he went to see the psychologist, he cried during the session. Now, perhaps his facial pain, he has facial pain. Perhaps his facial pain arose because he was trying to attempt to expiate guilt. He was trying to attempt to expiate guilt, and he has pain in his face. Next, please. Now, the last one would be something very interesting. I don't know whether you have come across. This is something which, let me see. This is a German word. It is pronounced Mannhausen. Mannhausen, but in English it is Mannhausen. This Mannhausen syndrome, when people try to convince others, the doctors and other people, that they are sick, but actually they are not sick. They want sympathy from people. So therefore they hurt themselves by making themselves sick. But in the oral mucosa, their ultimate goal is to get sympathy, so they will injure themselves deliberately to get attention. Now, this is self-inflicted wound in trying to get sympathy. But there is also this thing called Mannhausen by proxy. When people make others sick to feel needed. Now, normally this is most commonly seen between parents and their kids. They hurt their kids, cause few ulcers or cuts inside the mouth, and then take her to the hospital to get. So these are people who are not really stable in their mind, have got some emotional problem. Mannhausen syndrome. I have seen only 2 cases in my life because this is not very common. Mannhausen syndrome. Next. Right. Chronic orofacial pain with no known local cause. If we have, as a summary, chronic orofacial pain, patient coming to you with orofacial pain, but you are not able to pinpoint what is the cause of it. This is the thing that you must do. Always ask questions. There is pain, but I cannot find any cause. You ask questions. Is there any neurological sign to this or not? Ask this question. And then if the answer is yes, then it is neurological opinion that you need. Therefore, you send it to your colleagues who specialize in neurology, and between you and him, you manage this patient. If the answer is no, there is no neurological signs, then you got to send it for MRI of the brain. No psychology mind, maybe from the brain you can see something, yeah. And abnormality. Is there any abnormality in the MRI? Yes, there is abnormality in MRI. Back to the neurological people, right? For the opinion, for working together to treat this person. If the answer is there is no abnormality, then CBT. What is CBT? It is not criminal breach of trust, but it is CBT is not criminal breach of trust, but cognitive behavioral therapy. Cognitive behavioral therapy. In this case, the psychologist would try to help this person to change their attitude, to change their way of thinking, to accept things which is normal back. And it works, CBT really works. But you have got to have a proper person to conduct it. Ordinary dentist like me may not be able to do it. So pain resolve, if the pain resolve, that's fine. If no, then antidepressant trial, psychological opinion, go to the psychologist. So this is the thing that you might want to do. Okay, next. I hope this is the last one. Yeah, it says thank you, but it is now hidden by the last Chinese word called xixie. We now know there are 2 big powers in the world today. It is the Western world and the Chinese world. So I try to, cater for both. Next, thank you very much. Can I have the last slide then? I think that is the last slide. That is the end of this, whatever presentation that I had to give you. Believe me, it is not easy. Dealing with psychological pain, it is not easy, because we are dealing not with machines or instruments, but we are dealing with the mind. If the mind can change, then it can help. But if the mind cannot change, then it will be very, very difficult. But of course, the dentist must not take the sole responsibility of treating people who are mentally ill. Dentist's job is actually to help when it comes to the management of especially the oral problem. When it comes to the pain and so on and so forth, you might be able to handle it, or if it has gone beyond your capability, you must never hesitate to suggest that the patient come and see a psychological doctor. Never use the word psychiatry, because they will not go, because they will tell you, I'm not mad. Truly, they are not mad. True, they are not mad, but they are disturbed mentally, not amounting to madness or loss of faculty. It doesn't amount to that, but they have been derailed a little bit in their mental capacity. All we can do, all of us in dental profession, medical profession, psychiatry especially, is to put a back, and the family, of course. Family must support, and the friends must support. And we could put many of them back to the onto the rail again, even though sometimes not fully. But it doesn't matter. Nobody is perfect anyway. Thank you very much. Thank you for listening to me, and I hope you had benefited from it. I just hope. It was a big pleasure for me, really, to have been spoken to you. But all right, now that you have got a background like that, you can see the background there, the painting. I'm moving aside. That I painted that painting about 2 years ago. It describes me. It describes me. Now that painting describes me. People like me and people of my age are sailing into the sunset, leaving to the young ones to manage the profession and the country. So the young ones are the big fun, the big sailing boats, whereas us who are late in their lives must sail toward the horizon into the sunset, and giving the world for you to, each time for you to manage. And each time I look at this, I look at our country, old fellows like me, old fellows who have been around, I think should sail into the sunset, and they give all the chance to the younger people to develop whatever they have to develop, while we could act only as advisors if needed be. Thank you very much, Professor Dato Ibrahim, Muhammad Ibrahim Abu Hassan. It is indeed a great pleasure on me to be appearing in here, and I thank you very much. Thank you and your committee for inviting me. Thank you.
Okay, thank you very much, Dr. Hashim, for the very informative lectures. And we have with us here our president, Dato Hao Kim Chuan, Section 15. Dato Hao, you want to say anything to our speaker?
Yes, thank you very much, Dr. Hashim, Professor. Right, we are really old friends, huh? All right, and as usual, I always enjoy your lecture. You always have a mix of humor, and also you're always very creative in your presentations. And this is a very big topic. I'm very impressed that you presented it in such a well-defined way, from psychology, psychosis, all the way anxiety, all the way down to the dental pain, atypical dental pain, right? So really, this is not my forte, so I don't really have much question to ask, but I only have one thing that always crossed my mind, is that, right, all these psychological pain, dental pain, somehow are all related to one central cause, central nervous system, right? Plus the autonomous nervous system. That is the interaction with that cause this pain. All right. Maybe Prof, you can enlighten me on that.
Yeah, it is very right. Of course, without the brain and the central nervous system, we will not feel anything. In fact, that is the main place, right? But then in psychological pain, there are a lot of enzymes and hormones that comes pouring into the position which normally will not pour in under normal pain, which we know the results. But normally things like pain due to, say, depressions, anxiety, and stress, normally it is a disturbance in the dopamine system of the brain. So if you have this, it is the dopamine system of the brain that comes in there and then it will affect it. All right. So this is why we don't find any cause of it, because it is this thing which is a play of it. And that is all I think I can tell her. But for a deeper thing, it would be nice to be asking the psychological people, the psychiatrists and so forth. But basically that is the basic thing. Very many other cascading enzymes as well as hormones that play a lot of part in it. Yeah, Prof. Dato Hakim Chuan. We went to Xi'an twice, yeah? Yeah, many years ago before COVID. And of course, this is where I learned to write that Mandarin manuscript. Was the writing okay?
Yes, very good.
I tried to attempt to pronounce it, but then I thought, you know, they might be laughing at me. So I just write it now. Now, I thank you for asking me questions like that. But I forgot to tell you this little thing. When the patient said to me, have you ever seen the red rain? Come and sit in my brain and feel the pain. And I said, I will answer it later, because he was poetically describing it to me. I said, I'm being the doctor, I cannot lose out to my patient. So I said, at the end of the treatment, I will reply to you. So while doing the thing, whatever I was doing, I was thinking, how am I going to reply this guy so that he is happy? So I said this, I have said in your brain, witness your red rain and felt your pain. Right? Stay with me and remain calm. Better things are yet to come. The fellow just smiled at me and said, will it? Will it? I said, God, you and me will make it come. And then he left my clinic without paying the bill. He was happy to go away without paying the bill. I was very happy that he was happy to leave the clinic, right? So that is what happiness sometimes. You know.
Thank you, Professor Dato Hashim, for the lecture and also for answering the Dato's question. Maybe people always say pain is in the mind. If the mind can control the pain, and the pain will go away. What do you think about that, Dato?
Yeah, actually, pain threshold depends very much on the culture of each of the race. Certain races are very resistant. Your pain threshold is so high. You box him in the teeth and he will just smile at you. But there are people, you know, with little prick, little jump. So, all right, pain actually is quite true, you know, in very, very many instances. Like, for example, I am quite resistant to pain. People can take my teeth without anesthetizing it. And until such a time when really it will become unbearable, only then I react. So in my case, my threshold of pain is very high. I suppose it is probably because I have been subjected to a lot of pain of variable degrees throughout my life. So I have learned to adapt to pain and not to complain too easily. Now, there are people who are born with silver spoon and golden plates. Little bit of pain will scream, they will make them scream. You will know, for example, there are quite a number of patients who are so scared of pain, and you have got to be so careful about this type of people. You know? Right. Pain in the brain, that's quite true. Can you control? But of course, there are certain amount which does not exceed the pain threshold. You can bear, you can control, but it does not mean you don't feel the pain, but you are able to control it, right? So it all depends on the upbringing, the culture, the belief, and of course, sometimes there is this hypnosis thing, Datuk, Prof, Datuk, both of you, that hypnosis can really shut the brain from certain things that you don't feel it. If you have that ability, you could as well. But I do not want to depend on my brain trying to control my pain, because there is a certain limit I can do it. After a while, I can't. I remember going to the dentist, recently. Gosh, I tell you, it was so painful. I just couldn't control it. I was bashing my thumb, my palm onto the seat, and the fellow refused to stop because he did not even notice me having a lot of pain. Okay, good question. I will study that. I will go and read about you can control pain by the brain. You cannot even control the wife with your brain. What more you can control the pain with your brain? I'm just joking.
Thank you very much.
It's terrible. Life is terrible without laughter.
Yeah, thank you very much, Professor Datuk Hashim, Professor Emeritus Datuk Hashim Yaakob, for sharing your vast experience with our members tonight. And on behalf of Section 15, I'm actually the Education Chairman of that Section 15. We would like to thank you for sharing with us. Of course, we have a lot of compliments in our chat box, congratulating you and thank you for sharing the experience with us. Okay, maybe we meet again sometime in the future, inshallah. We have another interesting topic. You let me know. I can invite.
Prof, yeah, I tell you because you said something. We have a few more minutes? You said we hope that we can meet again sometimes. Yeah. Prof, there is a pantun. Who here knows about the pantun? That one day we shall meet again. I'm sure ada. Kalau ada sumur.
Kalau di ladang.
And then?
Kita dapat berjumpa lagi.
Kalau ada sumur di ladang, boleh saya menumpang mandi. Sumur min perigi telaga. Kalau ada umur yang panjang, boleh kita berjumpa lagi. Itu Amelia is your staff, Prof?
Amelia is one of the committee members of our education committee. She is in Indonesian. It's not Malaysian. Indonesian.
All right. Perhaps she likes to answer the pantun.
I'm not sure.
Or you like to answer the pantun because pantun cannot go off without answering. Kalau ada sumur di ladang, boleh saya tumpang mandi. Kalau ada umur panjang, boleh kita jumpa lagi. So please reply that.
Okay.
Datuk, how you can because you are smiling. I tell you how easy it is to reply a pantun. Because he said, kalau ada sumur di ladang. He was saying that kalau ada, then your reply will be kalau tiada sumur di ladang. Just borrow his word. Just say kalau tiada sumur di ladang, boleh saya menumpang mandi. Dia katakan, ke rumah saya datanglah mandi. Kalau tiada umur panjang, dalam surga berjumpa lagi.
That's a good one, Datuk. Thank you very much.
Always remember that because people will always sell you pantun and they just reply it. And then they will always remember it. So that's it, Mark. I always enjoy doing this sort of thing.
Right, thank you, Datuk. Inshallah, selamat berpuasa next week. As usual, again, the Section 15. Thank you, Datuk. And with this, I also take the opportunity to announce that for next month, April, we will stop for a while because of the Ramadan, and then we will continue our webinar in May. Okay, in May, we will have this presentation from Thailand. From Thailand, she is the Dean of Khon Kaen University. She would share with us the topic of breastfeeding in oral health. Associate Professor Waranur Fitapet is the Dean of Khon Kaen University. So we'll meet again on 11th of May. At same time on Wednesday, 9:30, to listen to our speaker, this time from Thailand, the Dean of Khon University. Till then, we meet again, and for all the Muslim members of ICD and in this platform tonight, we wish you happy Ramadan from Sunday onwards. Till then, we see you again in slightly more than 1 month's time for our next speaker. Thank you, and thank you again to all our members, the committee members, Datin Dr. Mayuna, and also Dr. Amelia from Dato' Hashim, our committee is international. It's not just Malaysian. We have
of course, yes. Yes, and that is good. It is very good of you to band together and make it international. Yes, sure.
And our participant also tonight right from Hong Kong, from Cambodia, Thailand, India, okay, and also Middle East and Pakistan. Right. Thank you very much, and good night.
Thank you. Good night.
In the future. Thank you. Thank you, Dr. Hao, for joining us, and thank you all. Thank you, Ami, and also Datin Mayuna. And good night.
Good night. Good night.
Good night.
Assalamualaikum.
Salam.
Waalaikumsalam.